And welcome to all to our Discussions in Diagnosis series that aims to raise awareness about diagnostic safety issues and foster collaborations and a culture of continuous improvement in diagnostic excellence. And the series is brought to you by the Advanced Center, advancing diagnosis through validated analytics and novel collaborations for excellence, established in 2022. And Dr. Gotham Rao is the PI, and then I am also one of the co-PIs. And the center is funded by the Agency for Healthcare Research and Quality, Diagnostic Centers of Excellence, and they are partnerships to improve diagnostic safety across the country. So we are so grateful to welcome today Dr. Kelly Gleason, who is an assistant professor at Johns Hopkins School of Nursing, and she was an inpatient nurse prior to returning to school for her PhD, and much of her research is based on the system level issues that she saw as a nurse. At Hopkins Center for Diagnostic Excellence, she leads efforts to engage patients and nurses in the diagnostic process. So we're so grateful to have you here this morning, Dr. Gleason, to share your perspectives on diagnostic safety and quality, particularly from nursing and patients' perspectives. And we've been hearing more and more about the importance of interprofessional perspectives and the systems and patients and family voices in understanding how we can achieve higher quality in diagnosis. So just to start us off, can you just share a little bit of your perspective as a nurse? What were some of your observations at the front line and when you were leading your career in nursing?
Thank you so much for that introduction, Mary. Yes, I can share, and there's many little things that happened that led me towards this direction of considering the role of the nurse in diagnosis in ways that we could I wouldn't say strengthen that, but just make it clear of making sure that nurses can practice to what they're trained to do and what they're like highly capable of doing. And there was one incident in particular where a patient who was about my age, and to give some background, I have always mostly worked on medical surgical floors. And so on medical surgical floors, you don't have the team right there. You being the eyes and ears of the teams and noticing when things are happening and communicating when things are happening and communicating that urgency is extremely important. So either way, we had a patient about my age at the time, who's mid-20s, transferred up from the ED. We knew that he had some abdominal pain. We knew that he was getting a drain, that he had place checked out. And he started rapidly just being in a lot of pain, a lot of anxiety. We called a rapid response. And what I noticed is that about myself is that once the rapid response team came in there, I became very task focused. And that was how the team was also seeing me is, okay, these labs, hang these fluids. Meanwhile, the patient was still mainly talking to me as someone who they had known before from prior admissions and was telling me, Miss Kelly, my stomach is growing right now. It feels so unusual. It is in so much pain. It is, you can see how it's just rapidly growing. And the dad was also noticing that. And again, the team, there were doctors in there. It felt like, okay, those people are in charge of the diagnosis. They'll eventually ask me, or they'll eventually ask the patient. I'm going to keep on focusing on all these tasks. Um, and ultimately, he transferred to the ICU, and within 2 hours or so, he died of an abdominal aortic aneurysm. And if you're familiar with abdominal aortic aneurysm, one of the telltale signs is that rapidly expanding abdomen. And so had I been more vocal, had I stepped up and said, hey, this is, the patient is saying this, I'm noticing it from, I know that we're focused on all these different things that could be causing this decompensation, but this is something that we might be missing when we're only looking at all these numbers. It could have changed the diagnostic trajectory. It could have led to a little bit faster treatment for it. And then the other thing that struck me about it was that after that, I was never involved in any conversations about, debriefing what happened. But I found out that there were morbidity and mortality rounds on it. There were reviews where they had gone over how everybody could have done things differently, but they were only among the physicians. And meanwhile, I felt like I had done something that, again, I'm not being overly hard on myself. But I could have made a difference. And knowing that the nurse didn't speak on there was a major breakdown, but it was never addressed or noted. I only knew that the morbidity and mortality rounds happened because I had friends who were there who told me more in an offhand way, not in a way like, oh, you should have, we all recognize that, the nurses should have been there. So it really just made me think about how we are such a part of diagnosis. We are the information that we collect, that we gather, how much we're with the patient and able to recognize some changes in their status is so key. And if we are not ourselves, it's a bi-directional thing. If we aren't ourselves saying, wow, I'm a part of this and I'm just as responsible for making sure that information gets there as I am for taking labs, everything as the physicians for reviewing all this information. They're also responsible for talking to me and seeing what, changes I've noticed. And shortly afterwards, it was like a magical thing where I'd heard a talk on diagnostic safety and the need for nurses to contribute. And I went up and talked to the speaker, who is our head of Center for Diagnostic Excellence, David Newman-Toker. And ever since we've been working together.
Huh. That's pretty serendipitous, right?
Yeah,
That you
yeah,
had the
yeah.
experience.
Yes, I came up and I was like, I literally just had this happen a month ago. It's
Yeah.
been on
Well,
my
see,
mind nonstop. Yeah.
seems like it was meant to be, and I agree with you that oftentimes I think nurses don't realize they're part of the team, and that part of teamwork is really to speak up and share your view, and not always passively waiting for someone to ask. There's a lot of literature in that with mutual learning and then also with advocacy and inquiry from Senge in systems approaches, to care delivery. And so it seems that then this early experience then led you to more scholarship or inquiry or more science, especially seeming that you were inspired during that presentation. So tell us a little bit then how your path went to your first study or your first inquiry into this area.
So one of the first inquiries was maybe focusing on the negative side of it, which is malpractice claims, and part of that was in an effort to just think of different ways that could get people to health system leaders and such to take it seriously. That if we're not making sure that each nurse has the time and the resources to be a part of the diagnostic process, that bad things could happen. So I did a review of malpractice claims that were labeled as involving diagnostic issues and also named nurses as a member. And I looked at what were the most common reasons. And this was a database available through CRICO. They help health systems manage safety and legal risk.
Hmm.
And uh, and I found that disproportionately the reason why nurses were named was unsurprisingly because of the communication breakdowns, because they had documented or there was evidence that they had noted a change in signs and symptoms, but that was not communicated to the physician team.
Hmm. I'm wondering even if there's much awareness in nursing as a profession or even being taught in nursing school, our responsibility in diagnostic excellence. Any thoughts on that?
I I think that I'm trying to think of how to say this. I think that sometimes it feels like or at least again, and I don't want but it can feel on the floor like you're so unbelievably busy and so
Mm.
many things are happening at the same time that when you notice something that you're a little worried about, um you send the page saying it, and then you document the little, like MD aware or like notified MD, here's a
Mm.
page, and then you go on to do other things. And I think really when you notice something that you think is an impending sign of deterioration, your responsibility goes a little beyond just sending that page to like, how can we be as honest as possible? How can we then look and make sure that's followed up on? And what I saw in some of the cases is that people who had is that sometimes just a page, but then no farther follow up, no farther closing the loop, no farther making sure that something actually happened. That was still named as an issue.
Hmm. So it seems like there's systems changes that need to be looked at and examined, and then possible solutions for how the nurse can, continue with the pattern of following up and continuing with the communication, due to some of the situations that you have identified. So, what was your then awareness of communication? Did that lead you to more inquiry or more scholarship or more research?
Um, I also did with Maureen Cahill, who I think has since retired, but she was on a state board of nursing, and a big thing that we heard was it was against the scope of practice for nurses to be a part of diagnosis. And we did a state by state review of each state's language around diagnosis. And we found that it really wasn't the case that there was specific language barring nurses from contributing to diagnosis. And really what we're talking about, which is, recognizing signs and symptoms and communicating and seeing that, it's your responsibility to make sure that that loop is closed when you notice something is very much so part of the scope, not outside of the scope. Um,
Ah,
but I do have some slides. This is on, and I do have slides. I'll try to go
yeah,
fast.
yeah, great.
But I will say that for whatever reason, I chose the most complicated terms to start this analysis in. So I'll try to
Okay.
use
Well,
easier terms. Um, not
did you want to share your
not that it's
screen or? Oh,
not
there
that
it
it's not a
comes.
highly intelligent group. It's more just that my own speech. I'm like, I don't want to say occult hypoxemia 50 times. Uh, so so the background for this, and some of you are likely aware of this, but pulse oximeters underperform in it can underperform in identifying when somebody is low oxygen. I call it occult hypoxemia, hidden hypoxemia. Basically, the pulse oximeter is showing that the patient's okay. You check an ABG and you realize that actually the patient has, their oxygen's in the 86% and it just is in the 80s and it just wasn't caught. And this disproportionately happens in people of color because of melanos, because it's likely the pigmentation is interfering. And this, during COVID-19, for example, when this was we only had so many ventilators, we only had so much treatment, and you're trying to make decisions about who's going to get the ventilator. This led to people, by as much as 20% not getting the treatment that they needed,
Mm.
and that was disproportionate by people of color versus white skin, again because pigmentation was interfering with the ability to make the clinical decision. So why do I care about that? So this is kind of focusing on the positive sign. And, they call it like the spidey sense, the nurse intuition, but really I think it's an experienced, what all know it is that an experienced nurse is able to pick up on these subtle signs and symptoms that don't really have an objective number assigned to them, but they can see, okay, I know this, I've seen this pattern before, this patient needs some help. And so what I looked at is this particular flow sheet in Epic of notifying the provider, nurse practitioner, the care team. Uh, it's where you document when you paged someone for a result and why. So we documented the frequency of that in the 4 hours before occult hypoxemia was confirmed. And so that we call those paired readings. It's when both an ABG and a pulse ox were done within 10 minutes of each other. So we can confirm that it was the case that the pulse ox was saying the oxygen was fine, and the ABG was saying, no, we need some help here. You're in the 80s. And so this is in a data set that we have of people 2020 through 2023. It is only patients with COVID. And it was looking just at the patients who had those paired readings. And there's 3 different types of paired readings we looked at. There's ones where there's a paired reading, there was an ABG and a pulse ox, but both were normal. There's ones where, I call it evident, but the pulse ox already did say that the patient was low oxygen. The ABG confirmed that. And then there's a cold where the pulse ox was good, the ABG showed bad. We use, sorry, lots of words on this slide, but we use multivariate logistic regression. And we did this so that we could account for all the different things that might lead to a nurse documenting or are associated with nurse increasing documentation. So this is, high heart rate, high respiratory rate, other concerning values. Then we also use conditional logistic regression, where we compared the exact same patients to 24 hours before in those 4 hours to see if it might have just been the case that the patient was leading to more documentation. What we found, and again, this is a lot of words, but I have a quick takeaway. What you can see is that occult hypoxemia was significantly more likely to be documented on in the 4 hours before. So that's after adjusting for all these different things. Nurses were recognizing, even in the absence of the pulse ox showing that there was low oxygen, that something was up with that patient. So they were 46% more likely in the 4 hours before occult hypoxemia compared to a paired reading not showing hypoxemia to document. And I think that's like pretty telling of nurses' recognition of something happening, even when they don't have that number to assign it to. We compared 24 hours back and kind of the same thing, 24% more likely in the 4 hours right before the occult hypoxemia in the same patients to be notifying that there's something happening with this patient. And again, this was after holding other things into the picture. Oh, sorry. Well, for conditional, it wasn't. But for the multiple, this was after taking several things into account that usually lead to nurse paging. So discussion, we found that nurse documentation does significantly increase prior to hidden hypoxemia. So looking at nurse pages might be a way to identify diagnoses where there's just not that specific number yet. Even if it's because of a faulty machine that the FDA still approved, but that's different. There's a lot of issues with this. There's variation in how nurses document. What time an action is documented at is often different from when the action happens and delayed. But I did want to say that this work builds on things that others have found, where nurse documentation can be is a predictor of inpatient mortality, in inpatient cardiac arrests, and that Brian Stites over at Vanderbilt has done a really cool study that showed that of all the early warning systems out there that have been heavily validated, all that, nurse paging alone is actually a much better predictor of impending deterioration than any of those early warning scores, just looking directly at nurse paging. So it's the more that we can get that moment that the nurse is feeling something in, the quicker for these inpatient diagnoses that need to be acted on fast, we can potentially act on them. Oh, I did add, sorry, this was just a side thing. I was thinking about this, but this is our state-by-state review, but that was,
Oh,
yeah.
yeah. No,
Yeah.
great. Great. Well, that's very compelling, I think, research to kind of bring about a whole nother perspective to the nurse's role in diagnostic excellence. And I think I'm an implementation scientist, so I always think about, well, how would we implement those findings? How would we make other healthcare professionals, physicians, and um, aware of the power of the nurse to detect those, that change in condition? Um, have you had any thoughts about like next steps on that or?
I can tell you that for me, a big next step is that I find that when I look at these early warning scores, and because of new AI functionality that's embedded in a lot of our electronic health records, it seems more and more likely that these early warning scores are going to be able to be used in real time. That if you don't have a nurse at the table, an actively practicing nurse, and I don't even count myself that. Like I'm increasingly,
Mm,
my information is increasingly outdated. But if you don't have somebody who knows what's actually happening, like on on the floor, on the units, on the floors, then they're going to be misguided, and they're not going to take into account reasons for error that might exist. They're not going to take account other sources where where a nurse might be putting information when they're worried. And then also, if you're working more hand in hand so that people know exactly what information is feeding some of these early warning systems, then nurses can better partner with you in saying, okay, like if they're using this field, and so we know that we have to put something in this field when we're getting worried, versus just a lot.
mm,
I read so many of these, even from like the best, most interprofessional minded clinical research teams, and I see that they're doing it all without talking to their nurses. And
Mhm.
nurses are the main creators of all that information. And if you're not talking to the people who are actually entering in the information that you're planning on drawing on to then, predict impending deterioration, then that's a pretty big miss.
That's a pretty big mess, yeah. That's very interesting then to think about standardization of where the nurse would document concern. And then that like documentation field could be then integrated into the like the sepsis protocols or the early warning detection AI systems.
Yeah, and there's some pretty cool work done by a nursing team at University of Maryland in partnership with Vanderbilt, and we have a little site here too, to look to look at nurse documentation, and it's really interesting because there's so much variability, not only just from like unit to unit, hospital to hospital, but even just like two nurses working on the same unit of how we are taught and what our style of documenting is. Like mine used to be just free
Yeah.
text notes everywhere, whereas
Hmm.
others will like, have found out where to put it in the flow sheet and how to add different flow sheets in. And even, the study that I made that shows 46% more likely that it's actually probably higher because I wasn't looking at the free text notes that are
Mm.
also in all these other places. And
Yeah.
but I don't think nobody's trying to work against you or make your job harder. So if nurses were told, hey, actually this area matters the most, and this is the area that the providers are going to touch, are going to check, and that is going to feed into the system. So if you're going to document that you were concerned enough to page, like it has to be, and you want it to be used, it has to be here.
Right. Yeah, it's a good idea. Wow, really fascinating. I love your journey in this area. It seems like you were born to do this work. So the cards were laid out. So I'll just pause to see if anybody on the call has any questions. And if you do, you could either put them in the chat or if you want to just open your mic.
Hey, Mary, I have a question. It's Esther. Kelly, I'm a nurse scientist with university hospitals, and really want to promote the role of the nurse. I was also a med surg nurse back in the day, and I feel the pain. And just wondering what would be some ways that we could institutionalize like nurse-led um, authoritative bodies on early detection systems. Like I'm thinking about our sepsis teams and some of our other sort of what we call our zero harm teams that are really focused on specific high risk events like CODIs, CLABSIs. Like the nurses are integrally involved in those teams. What are some ways that, in terms of implementation, that we could better institutionalize nurses to be authorities and at the table and the decision making around these systems?
Yeah, it's funny they say sepsis because I use sepsis as my example of like nurses are doing so much of this work. We just like don't label it as that. But like sepsis is, I would say, like if not nurse led, very, very largely nurse contributed to a campaign, and that has been like extremely widespread. I would say successful, but it's a really hard question though to answer, Imaz. I think that the more there's kind of two different ways that I've been thinking about. I know I only have 2 minutes left, but one is focusing on specific conditions that are
Mm.
that are high risk and get everybody's attention. So things like detecting inpatient cardiac arrest, and like a nurse team around that, which is like a major diagnosis that's often missed, versus the more like condition agnostic style, which is like a nurse deterioration team. I think the diagnostic world as a whole kind of struggles between whether to focus on one diagnosis at a time versus to be more condition agnostic, because ultimately a strong focus on diagnosis will lead to many different conditions being correctly picked up versus only one. Esther, this is a nothing answer. It's a very hard question. I'm sorry.
Well, maybe we'll have to have another
Yeah.
discussion and diagnosis to maybe go a little deeper into this topic, which I think we can. So grateful for your time today, Dr. Gleason. We've gained and learned from you and your work, and we wish you well in your future endeavors. And I think maybe we'd like to invite you back. So that would be a great asset to our community. So thank you again.
Thank you so much, Mary, and thank you, everybody. Yes,
Yeah,
I was time.
Oh, good. I'm glad you'll be coming back. And thanks to all for coming on the call this morning. Have a wonderful day.
Thank
Thank you,
you.
Okay.
everyone. Have a great day.
Bye-bye.